Hello everybody, thank you for joining me today, and in today's video we're going to be looking at atrial fibrillation for finals. So just a little bit about the medicine guide. So the medicine guide aims to support medical students throughout their entire journey at medical school. So I've made videos such as how to be successful in the pre-clinical years at medical school, how to be successful during the clinical years at medical school, how to get the most out of GP placements, how to get the most out of hospital placements, how to succeed in your clinical OSCEs, and I've also made a video where I'm focusing upon the high yield paediatric topics for final exams, such as a child with a mass, a vomiting child, congenital heart disease for finals, high yield rashes, high yield limping child, and high yield genetic conditions for finals. Similarly, I also have an obs and gynae edition focusing upon the high yield topics for finals, such as the causes of chronic abdominal pain, high yield gynecological cancers, high yield causes of acute abdomen, high yield obstetric emergencies, and high yield STIs for finals. So this video, in conjunction with many others, makes up the high yield cardiology edition. So today's video is focusing upon atrial fibrillation, but other videos focus on pleuritic chest pain for finals, infective endocarditis for finals, aortic coarctation for finals, and high yield electrolyte disturbances with ECGs for finals. So if you enjoy my video today, please give me a thumbs up, please subscribe to my YouTube channel, and please share with your family and friends. So let's get started. So the outline of today's video is that we're going to be discussing the causes of atrial fibrillation, the types of atrial fibrillation, the signs and symptoms, complications, tests and investigations, and finally the management. So atrial fibrillation typically describes an irregular pulse, and it presents on an ECG with an irregular rhythm. So let's get started with the causes of atrial fibrillation. So atrial fibrillation is caused by an irregular, disorganized electrical activity leading to ineffective contraction of the atria. So ectopic triggers are typically localized near the pulmonary veins. So this leads to multiple re-entrant circuits. And when the AV node receives more electrical impulses than it can conduct, it leads to this irregular rhythm. And that irregular rhythm is recorded on an ECG. And when you palpate the pulse of a person with AF, they will have an irregular pulse. So I like to remember the causes of atrial fibrillation with the mnemonic dehydrated pirates. So dehydration. So the mnemonic pirates will involve pulmonary disease. So pulmonary disease can include PE, pulmonary hypertension, COPD. I for ischemic heart disease like hypertension, heart failure. R for rheumatic heart disease and mitral valve disease. A for anemia and atrial myxoma. T for thyrotoxicosis. So that's essentially when a patient is in a state of hyperthyroidism, so they'll present with high levels of T3 and T4, so high levels of thyroid hormones, but their TSH levels will be low. E for ethanol abuse and electrolyte disturbances. So with the ethanol abuse, that's an example of binge drinking, and patients will classically describe this as sometimes as a holiday heart syndrome. And electrolyte disturbances involves hypokalemia and hypomagnesemia. And finally S, so sepsis and sleep apnea can also be potential presentations of atrial fibrillation. Okay. So now we need to focus on the types of atrial fibrillation. So there are 4 types of atrial fibrillation. There's a first detected episode of atrial fibrillation. There's paroxysmal atrial fibrillation, persistent atrial fibrillation, and finally permanent atrial fibrillation. So let's focus on this in a little bit more detail. So first detected episode of atrial fibrillation is exactly what it says on the tin, the first episode, whereas a paroxysmal atrial fibrillation are recurrent episodes of atrial fibrillation which spontaneously terminate within 7 days. So because these episodes spontaneously terminate within 7 days, no medication is needed. In persistent atrial fibrillation, these are episodes of atrial fibrillation which persist for more than 7 days. Now, because they're persisting for more than 7 days, these are not self-terminating and therefore medication is needed. And finally, permanent atrial fibrillation is when patients have atrial fibrillation despite receiving cardioversion. It might be a situation where the atrial fibrillation has been terminated but then relapsed within 24 hours, or atrial fibrillation that persisted for more than a year, but cardioversion is inappropriate or not attempted. So in this situation, it might be where the patient and the cardiologist have accepted that the patient will remain in permanent AF, so no medical management is offered. So now let's look at the signs and symptoms of atrial fibrillation. So I've mentioned previously, classically it will present as this irregularly irregular rhythm, and that's something that you can palpate that's something that you can find on general examination when you're palpating for the pulse. Patients might also complain of chest pain, breathlessness, syncope, reduced exercise tolerance and palpitations. So now let's look at the complications. So atrial fibrillation is a major risk factor for ischemic stroke. So atrial fibrillation is a source of potentially thromboembolism. So these thromboembolisms can, as the name says, they can throw off clots, and this can lead to an emboli lodging itself within the cerebral circulation, leading to an ischemic stroke. Also, the risk of an ischemic stroke increases during cardioversion of a patient suffering from atrial fibrillation. So during cardioversion, this is when we're trying to revert the irregularly irregular rhythm back into normal sinus rhythm. And during that process, the patient is at an increased risk of developing an ischemic stroke. Another complication of atrial fibrillation involves heart failure, tachycardia-induced cardiomyopathy, cardiac ischemia. So now let's look at the tests and investigations. So your first line investigation for atrial fibrillation is an ECG. So if you have a look at the ECG at the top, this is an ECG tracing of a normal heart rhythm or a patient with normal sinus rhythm. If you have a look at the ECG below, this is an example of atrial fibrillation. So the patient has an irregularly irregular pulse. So if you look at the RR interval, the RR interval changes amongst the QRS complexes. So the first RR interval is a little bit more than 2 squares. The next RR interval is 2 squares and then 2 squares, but the next RR interval is 4 squares, and then it becomes almost 1.5 squares. So the distance between each R wave, so the RR interval, varies along the rhythm strip. So that's why it's known as an irregular rhythm, and it's known as irregularly irregular because, as I mentioned before, the RR interval will vary with each complex. It's not as though each complex will have an RR interval of 5 squares and then 4 squares and then 3 squares, and then the pattern will revert and begin once again. In atrial fibrillation, the distance between each RR interval can't be predicted. It's so irregular, and that's why it's known as irregularly irregular. Furthermore, no concrete or discernible P waves are visible. And there's also fibrillation waves between each heartbeat. So those are the key signs of atrial fibrillation on an ECG. So like I said, no P waves and the irregularly irregular rhythm are two classic signs of atrial fibrillation on an ECG. And these are the two signs that will most likely be expected of all medical students, especially final year medical students, to be able to identify on an ECG both during a knowledge paper exam and similarly during your OSCEs. Other findings of atrial fibrillation on an ECG includes a narrow QRS complex, fibrillation waves and a chaotic baseline, but I would say the two most important for you to always remember are the fact that patients with atrial fibrillation will have an irregularly irregular rhythm and there will be no obvious P waves present. So further investigations includes a 24-hour ambulatory ECG if a paroxysmal AF is suspected, an event recorder ECG where symptomatic episodes of paroxysmal AF, which could be more than 24 hours apart, and a 7-day Holter monitor, which is an alternative to an ECG, so it allows more longer term monitoring, and this is when the healthcare professional is suspecting asymptomatic episodes of paroxysmal atrial fibrillation. Healthcare professionals can perform a full blood count, so that's when we are investigating for leukocytosis. So leukocytosis involves raised leukocytes because in this situation we might be considering if there's an underlying infection, because one of the causes of atrial fibrillation is sepsis. So in sepsis, the inflammatory markers, leukocyte count will be raised. Also, another reason for performing full blood count is to investigate anemia, because we mentioned beforehand that anemia can be a risk factor for atrial fibrillation. Other tests include performing U's&E's to exclude for hypokalemia and hypomagnesemia, because again these are risk factors for atrial fibrillation. Thyroid function test to exclude for thyrotoxicosis. So thyrotoxicosis will present with elevated levels of thyroid hormones, so high levels of T3 and T4, but low levels of TSH. And an echocardiogram, which is present on the right hand side. So an echocardiogram is used to evaluate the ejection fraction and also to exclude for any atrial thrombi, because I mentioned previously that atrial fibrillation increases the risk of an ischemic stroke because potentially it can lead to thrombi being dislodged. Okay, so the management of atrial fibrillation will vary upon whether the onset was within 48 hours or if the onset was after 48 hours. So let's firstly begin by looking at a situation where the onset of atrial fibrillation is within 48 hours. So if the patient is in a state of hemodynamic instability, they will need emergency DC electrical cardioversion. So hemodynamic instability is a situation where the patient's pulse rate is more than 150 beats per minute, their systolic blood pressure is less than 90, they're suffering from a loss of consciousness, they're suffering from severe dizziness, syncope, chest pain and breathlessness. So those are all features of hemodynamic instability, and these patients need emergency DC electrical cardioversion. Now, if the onset of AF is within 48 hours and these patients don't have any signs of hemodynamic instability, these patients can receive either rate control or rhythm control, and that's something that I'll discuss shortly. If the onset of AF is after 48 hours, initially we anticoagulate patients with either warfarin or NOAC for at least 3 weeks, Then we perform DC electrical cardioversion, and then we anticoagulate the patients for at least 4 weeks. So previously I alluded to rate control and rhythm control, and that's something that I'll describe and I'll focus on now. So let's begin with discussing rate control first. So in rate control, that's when the healthcare professional and the patient accepts that the patient will remain in an irregular rhythm, but the whole point of performing rate control is that we're trying to slow down the heart rate to avoid any negative effects upon the cardiac function. So rate control is preferred in patients who are above the age of 65 or have a history of ischemic heart disease. So the first line management of rate control is either bisoprolol or verapamil or even diltiazem. So bisoprolol is an example of a cardioselective beta blocker, and verapamil diltiazem are examples of a rate-limiting calcium channel blocker. Now, the first line management of rate control in patients with heart failure would be digoxin. Now, the second line management is when a patient needs to add on digoxin to either the bisoprolol or verapamil diltiazem. Okay, so now let's look at rhythm control. So rhythm control involves either pharmacological or electrical cardioversion to revert the irregularly irregular rhythm back into sinus rhythm. Now, rhythm control is preferred in patients who are less than 65 years old, so they're younger than 65. These patients are symptomatic if it's their first ever episode of atrial fibrillation, if they're suffering from a lone atrial fibrillation, or atrial fibrillation which is secondary to a reversible cause such as alcohol abuse, or patients who are suffering from congestive heart failure, then rhythm control is something that is preferred. So I mentioned previously about how DC electrical cardioversion is an example which can be used for rhythm control, and examples of pharmacological cardioversion as part of rhythm control involves the use of amiodarone, which is preferred in patients with structural heart disease, and also flecainidine, which can be offered, and this is preferred in patients who don't have any structural heart disease. Now, patients might have initially used rate control, but then later switched on to rhythm control if the symptoms or the heart failure has failed to resolve. Now, the moment where a patient undergoes rhythm control and they're switching from their irregularly irregular rhythm back into sinus rhythm, then this increases the risk of emboli developing, and it can increase the risk of an ischemic stroke. And that's something that we need to keep in mind. Now, part 2 is when we're going to consider anticoagulation. Now, anticoagulation takes the form of warfarin or a NOAC, and we need to consider anticoagulation because we need to consider the risk of A, a stroke, and B, how to reduce the risk of a stroke, especially following rhythm control for atrial fibrillation. So we need to perform the CHADS-FAST score. So if you have a look at the top, you can see the mnemonic for CHADS-FAST, and after completing the CHADS-FAST score, we need to interpret whether or not we need to give the patient anticoagulation. So if their CHADS-FAST score is equal to 0, no treatment is needed. If the CHADS-FAST score is equal to 1, in men we can consider anticoagulation, and in females no treatment is needed. However, if the CHADS-FAST score is greater than or equal to 2, then we must offer anticoagulation to both men and women. Now, after calculating the CHA2DS2-VASc score, we need to calculate the has-bled score. So if the has-bled score is equal to 3, then this implies there's a high risk of bleeding, and we need to consider an alternative to anticoagulation. So as part of your second step in managing patients with atrial fibrillation, we have to perform both the CHA2DS2-VASc score and the has-bled score to see whether or not it would be appropriate to offer anticoagulation. Anticoagulation for atrial fibrillation takes the form of either warfarin or a NOAC. So now we're going to focus upon radiofrequency catheter ablation. So in some textbooks you'll see this described as catheter ablation, and other textbooks it's described as a radiofrequency catheter ablation. Those terms are used quite often and they're used interchangeably, so I've just placed radiofrequency under a bracket just so you're aware of the alternative name for it. So this is your final step, your surgical management as such, of managing patients with atrial fibrillation. So it's used in patients where atrial fibrillation is permanent or atrial fibrillation has persisted despite the medical intervention given. So if you have a look at the picture on the far right, you can see a ablation catheter, and you can also see a mapping catheter. So these catheters are examples of an intracardiac catheter where radiofrequency energy can be delivered. Now this energy will be used to isolate the ectopic triggers of atrial fibrillation. The majority of these ectopic triggers or ectopic foci for atrial fibrillation are localized to the pulmonary veins, which is something that I mentioned at the beginning of the video. So this intracardiac catheter will create a ring of lesions around the ostia of the pulmonary veins. Now, radiofrequency catheter ablation will control the rhythm, but it doesn't reduce the stroke risk. So again, we would need to consider anticoagulation in these patients. So I mentioned previously that atrial fibrillation is unresponsive to medical therapy, and if that's the case, then you would have to use radiofrequency catheter ablation to help manage those cases. It can be given in patients who want to avoid any antiarrhythmogenic medication. Patients will need to be anticoagulated 4 weeks before the catheter ablation and also during the catheter ablation. So anticoagulation in these patients will vary upon the CHA2DS2-VASc score. So if the score is equal to 0, these patients will need 2 months of anticoagulation. If the score is greater than 1, these patients will need long-term anticoagulation. Now, the complications of catheter ablation includes an ischemic stroke, cardiac tamponade, and pulmonary valve stenosis. So thank you for staying with me. I appreciate it's been a very long video today. I just want to say that if you've enjoyed my video today, then please give me a thumbs up. Please subscribe to my YouTube channel. Please share this video with your friends, and I wish you all the best of luck with your final exam. Thank you very much for watching my video today.